Very good morning to all of you. What a stage set by Dr. Sujit Rajan, sir. He told us why it is important to look for pH in every patient with chronic lung disease. We shouldn't miss group 1 pH in those patients. And also, it's not only important, even if you don't have the drug, then also it's important. He told so many things to go ahead with the pH. It's prognostication, transplantation. There are so many things. So that's there, and I truly believe that it made all the task easy for all of us. So it's my absolute pleasure, privilege, and honor to be here with all of you. And Airvana Foundation welcomes you to the first National Pulmonary Symposium, Hypertension Symposium, which is happening in collaboration with CIPLA. So now for the next 30 minutes, we would be discussing about how to classify the patients with pulmonary hypertension with comorbidity. It's not moving. Yeah. So before I start, I must pay my heartfelt gratitude to a few important people in my life, and Dr. Randeep Guleria is sitting here with all of us. He is my teacher. And when I was at AIMS, Delhi, I tell you, he's the only person who influenced me or who inspired me to an extent that I choose pulmonary medicine as my career. Dr. Talwar sir is arriving very shortly. He made sure that I had no absolute regret choosing this field. And Dr. Indu, all the academic designs you admire and whatever memories you're going to take away from here is credited to this lady. So thank you so much, everyone. So let's understand that the term pH is not a disease entity. It's just a hemodynamic state, which means that the mean pulmonary artery pressure is greater than 20 mm of Hg. But when we talk about clinical classification, the pH classification is not hemodynamic classification. It's a clinical classification. So when we are going to classify pH, we have to take consideration of the entire clinical picture of the patients. So why is it important? Because clinical classification of the pH will classify the patient in a group which has got similar risk stratification, which has got similar prognosis, and which has got similar therapeutic approach. So whenever you are going to treat the patients, you should classify the patients with pH. So how are we going to do this? Every diagnostic framework of pulmonary hypertension has a primary objective, and that objective is to raise early suspicion of the pH. So whenever you think of the signs and the symptoms, raise the suspicion of pH, and then go into identify the underlying disease and the underlying comorbidity. And finally, you will ensure the proper clinical classification of the pulmonary hypertension. So with this framework, this has been put forward before us by Dr. Sujit Rajan sir also. If you see on your left-hand side, we have the clinical classification of the pH. On your right-hand side, you see the hemodynamic subtyping. It looks so simple. You identify the disease, you identify the hemodynamic subtype. Yeah, what happened? It's not moving. Yeah. So you identify the disease, you identify the hemodynamic abnormality, you fit it together, you will find the classification. But the design is so simple, that's why it is so complicated. And I'm going to tell you why. From the registry data of PAH, more of the patients are diagnosed beyond the age of 60 years. And these are the patients who are likely to have cardiopulmonary disease. And not surprisingly, 60 to 85% of the patients with PAH have cardiopulmonary comorbidities. Not only this, most of the pivotal PH trials excluded the patients with cardiopulmonary disease. And you know what was the extent of those disease in those patients? Almost 50%. So there is a huge number of PH patients who have both cardiac and lung disease. So the question is, if a patient has pre-capillary hemodynamics and then have the risk factor for the cardiac and lung disease, is it justifiable to diagnose PAH in those cases? And how are we going to take this question? We are going to have a case-based discussion where we will see what challenges we face during the classification, and through those challenges, we would try to identify the treatable trait so that each patient can be offered right treatment. So here is the case. 74 years male, construction site worker, former smoker, 45 pack years, shortness of breath on exhaustion for several years, which is progressive over the last 6 months. Medical history is significant. Dyslipidemia and coronary artery disease, post-PTCA of LAD. Patient is on dual antiplatelet, atorvastatin, diuretics in the form of furosemide and spironolactone. Patient is severely hypoxemic at rest, using 4 liters per minute of oxygen. Primary hypothyroidism, using 150 microgram of altroxin per day. On examination, the patient has pedal edema with the murmur of tricuspid regurgitation. So this is the clinical history, and I would request Dr. Espirai, sir, to tell us, based on this history, what clinical differential diagnosis comes to your mind?
This patient, he's a construction site worker and former smoker, 45 pack years. So, and usually what the patient comes to up, like chronic lung disease patient, he had come with the dyspnea on exertion, which has increased during the last few months. And also, there is requirement of oxygen, roughly 3 to 4 liters oxygen requirement is there. The findings wise clinical examination, like what is shown is the pedal edema, the loud P2, so that points towards likely associated the pulmonary hypertension, the suspicion should come. Like you have already pointed out, the first step is this suspicion. So history wise, if we see, the first is mainly is a construction site worker. We have to keep in mind that thing also, because the occupational, the lung disease can also be there, it can be silicosis, asbestosis. So that we need to keep in mind based on the history. The former smoker, so we have to think of COPD or something like that. And obviously, over a period of time, it has progressed and involved the right side of the heart also. The suspicion has to be there. And further, we will go and investigate that case. So differentials will be, one is I will like to keep this COPD first. COPD, some occupational disease, maybe silicosis, asbestosis sort of thing, or some interstitial problem can be there. We need to see, and over and above, probably this increased breathlessness and this thing, I think is likely because of the associated, if he is developing the pulmonary hypertension. As he has already pointed out, we will be proceeding further to investigate this, because it could be mainly either because of the lung disease only, it could be because of the associated, the cardiopulmonary, cardiac problem is also there.
Thank you so much.
That may be the cause.
Thank you so much, sir. That was really great from you. Dr. Tala, are you thinking of any other differential besides COPD and ILD associated PH?
Yeah, I mean, the big elephant in the room is the coronary disease as well. He's had a angioplasty done to the LAD. But honestly, angioplasty, I mean, if this was an ischemic event, generally doesn't cause so much of increasing oxygen requirement unless he's in full-blown heart failure causing pulmonary edema and whatnot. So, you would have obviously mentioned Krebs or other signs of left heart failure.
So it wasn't there?
Correct. So that nicely rules left heart failure out of the equation. So makes it less likely. But I would still like to put up that amongst the differential list, given the other findings, pH does seem to be higher on the differentials.
Okay. So as our subject expert and both the panelists have pointed out, we had certain differential. Left heart disease with PH, one of the differential that came here, COPD with PH, ILD with PH, toxin-induced PH. We thought of it because the patient was construction site worker, and there was the chance of using paint sprayer, and the paint sprayer can cause toxin-induced PH. So this was the one of the differential we had. Then PH secondary to PA obstruction, the patient was on high-dose thyroxine replacement therapy. So, Dr. Tala, so do you, it is there in the literature. Do you find it, how?
Sorry, he was on high dose what?
Thyroxine replacement.
So, if you look at this, so just a few things I want to highlight here. So, the differential number 4, drug or toxin-induced pH, that's specifically looking at a very, very, very specific list of drugs. It's a finite list of drugs which is updated every so many years. And I don't think toxin sprays, pain sprays feature on that. It may contribute towards worsening, lung parenchymal disease component and then worsening pH, but drug toxin related pH has a completely different mechanism as opposed to, say toxic inhalation of fumes causing worsening lung disease. So that is one thing I wanted to clarify. Second, I have never seen anyone having, PA obstruction due to high doses of thyroxine. What the current classification, when they say pH associated with pulmonary artery obstruction, they are looking at mechanical obstruction, either due to thrombus, clot, or some rare tumors.
So, great.
Yeah.
So thank you so much. So finally, as Tala was talking, we had to consider idiopathic PAH also when we have excluded the other causes. So rightly, so what we have done, we have raised the early suspicion of pulmonary hypertension, and that is the first step in the diagnostic framework. So now the second task is to identify the underlying disease. So I would request Dr. Sanjay, what investigations would you like to do in these patients to identify the underlying disease?
Well, since the patient have features of breathlessness and oxygen requirement, we would like to do the tests for the lung diseases like chest X-ray, HRCT, followed by echo. Echo is very important to just measure the condition of the heart and how whether the ventricles, left ventricle or the right ventricles are working properly, right side of the heart is working properly or not. And at the same time, we can measure the pressure also. So echo is very important, and NT-proBNP is also very important to look whether the patient is in the left ventricular failure or not. So these tests are important, and then we can think of the right heart catheterization.
So we are not, actually we are going to investigate the underlying disease. So you have pointed out the disease. For LSD, you said the echocardiography that you will be doing. For COPD?
For COPD, the lung function test will be done.
For ILD, you are going to do lung function, HRCT, and finally idiopathic.
Yes.
So do you want to add anything else, Dr. Tala? So we went ahead and we did the chest X-ray, which showed right ventricular enlargement and the enlargement of the pulmonary artery, arterial blood gas, hypoxemia with hypocapnia, NT-proBNP highly elevated, ECG right ventricular enlargement with strain pattern. We did some routine investigations because the patient, we raised the suspicion of pulmonary hypertension, so HIV serology was done, it was negative. Autoimmune panel test was done, it was negative. USG abdomen was done, there was no evidence of portal hypertension. CBC and lung function test was normal. We had this PFT performed. So I'd request Dr. Abhijit, how do you interpret this pulmonary function test report in the context of this patient?
So largely preserved ratio. So your obstruction is not much. FVC is almost again borderline normal, but your DLCO is quite reduced. Alveolar volumes are also reduced. So, there is some evidence there which shows that, he's not typically a COPD yet. However, the drop in diffusion, actually we need to look at a CT scan to understand if there's anything else going on in the pulmonary vasculature, as well as look at the structure.
So fine. So such a disproportionate reduction, you want to have CT done, and also you want to, yes, sorry.
The mild restrictive defect, because the VC is only 74%. So there is mild restrictive defect, and also like DLCO is disproportionately very low, 25%, whereas KCO is like mild to moderate, I will put it as that reduced. The alveolar volume is also reduced. So predominantly it is pointing towards some restrictive type of defect.
Where we are going,
Not
we are
the
having
obstructive.
disproportionate
Like
DLCO.
COPD, I am not thinking of at present. I am thinking of some interstitial sort of process.
So I guess everybody wants to have CT, and we had the CT chest done with CTPA in this patient. And I'm not having the entire film, but I'm having some cut here. Dr. Vinay, would you like to comment on this?
The mediastinal window here is showing the trunk, pulmonary artery trunk is, the ratio is little on wider side, suggestive of the pulmonary artery hypertension. And CT scan almost parenchymal, there is no as such parenchymal disease.
So Dr. Thala, as a cardiologist, what would you like to say in this CT cuts?
So I'm going to skip commenting on the lung parenchymal part, but the mediastinal window shows very clearly that the pulmonary artery is significantly dilated, and so is the RV and RA. If you look at the RV LV ratio, the RV is is quite significantly dilated here.
That's great. I mean, and in the lung window, I would say that there is mosaic perfusion. Unfortunately, I don't have inspiratory expiratory film, but mosaic perfusion can happen with pulmonary hypertension of any cause. So we had dilated pulmonary trunk and arteries, enlarged RA, dilated RV, normal lung parenchyma, and I didn't put the any CTPA film, but there was no pulmonary embolism or pulmonary vascular abnormality. So somebody wanted to have echo.
I'm sorry, is the lung parenchyma normal?
Is normal, absolutely normal.
Okay.
Yeah, and the last investigation everybody wanted to have is echocardiography. So Dr. Narendra, our area of interest will be how are you going to interpret the level of probability of pH in this patient based on echo?
Yeah, first I would see the tricuspid TRV velocity. If it is less than 2.8, the probability is very low. If it is 2.8 to 3.4, I would see all this TAPC, PASP scores, RV ratio, IVC diameter, etc. Here we can see that TRV is more than 3.4. So that raises the high echocardiographic probability of pulmonary hypertension. And also we can see certain variables, TAPC, which is less than, which is 14, shows again severe, it points out to be severe pulmonary hypertension. Again, right ventricular outflow tract obstruction, acceleration time, usually less than 105 shows the probability of pulmonary hypertension. And the pulmonary diameter, we usually, there also it's more. And IVC is collapse, I mean, there is a decreased respiratory collapse. And as you point out, there is preserved systolic and diastolic left heart failure also.
So what is the echo probability of pH?
Very high.
Very high.
Very high.
So it's high. So Dr. Thala, our interest won't be knowing from you what is the echo probability. Our interest would be, yes, sure. So our interest would be why the echoes gives the probability of pH, not the diagnosis of pH.
Right, so the echo is designed to estimate the pulmonary artery pressure. If you've noticed, all the reports say it's an estimated PA pressure. It's trying to guess what the PA catheter or the right heart catheterization will tell us. There are several fallacies in both the PA catheter readings as well as the echo readings, but we always consider the PA pressures obtained on a right heart cath as the gold standard. Now the problem with echo in trying to estimate the pulmonary artery pressure is that Number one, it is a lot of operator dependent. If you don't get good windows, you may not get a good tricuspid regurgitation signal, which will affect your pressure readings there. And this is something that a lot of us, even as cardiologists, don't appreciate enough. How in patients who have significant tricuspid regurgitation, the TAPSE may actually be preserved, and it may, give you a false sense of comfort. You have to look at the whole right ventricular global function as opposed to only a longitudinal function. The TAPSE tells us what is the longitudinal excursion of the tricuspid annulus. It doesn't give you too much information about the global right ventricular function. That's just one aspect of looking at it. In patients who have significant tricuspid regurgitation, the TAPSE tends to be what we call a preload dependent measure. So if there's a lot of TR, I would say if there's moderate plus TR, then the tricuspid, then the TAPSE tends to be falsely preserved. So always take that number with a pinch of salt. We try to get more information about the global right ventricular function by doing things like right ventricular fractional area change, which can happen easily with basic machines. You just need a 2D measurements for that. And then if you have advanced software and better machines and good windows, you can look at 4D analysis and try to get the right ventricular ejection fraction, right ventricular GLS. These are more advanced parameters.
So I think you are very right. And I think all of us should ask our echocardiographer to give these, findings in the report whenever you have
At the least, this much. In fact, I would go on to say that we must not just purely take left atrium not enlarged.
Okay.
We should ask for the left atrial size, both in 2D diameter and indexed volume. It's not difficult. It's a basic measurement. The technicians or the cardiologists just have to report that. That's it.
Thank you.
Madhu, one second. Yeah, right.
Yes,
One doubt.
Yes, sure.
Dr. Tala, right. Yes, you made it somewhat clear to pulmonologists, but does this longitudinal assessment will also be a part of the oral assessment, right? So, why can't we take longitudinal assessment, the TAPSE alone, an important indicator in assessing the pH?
No, it's an important indicator, but don't get me wrong about that. However,
alone it cannot be.
No, not even alone. Sometimes it may throw you off. It may be preserved. So I have seen TAPSE of 17, 18 with a cardiac MRI showing an RVEF of 20%.
Oh.
So what I guess you are telling is that we should not rely on single echocardiographic criteria.
It should be taken as a whole.
Yeah. Right.
This much RV dilatation, and if you do a cardiac MRI, this TAPSE of 14, I would say, is based on everything mild dysfunction. If you do a cardiac MRI, this RV may not be as healthy as it seems.
Okay.
I would like
We
to
can
add.
So we can take further questions after the So now we have done all the investigations, whatever you asked for. So Dr. Abhijit, what is your differential diagnosis now? Are you ruling out LSD-PH or ruling in? You are still keeping this differential diagnosis in mind.
So looking at the echo giving us a good enough, like we said, the right ventricle may be, still not estimated well, but the left ventricle is, I think, fairly estimated well on an echo. So we can rule this out because the EF is preserved. And we move on to the next one.
Yeah, I'll go to the next one. But before that, I will again involve Dr. Tala here. I have this statement from ERS and European Cardiology Society guideline. Resting hemodynamics on right heart catheterization, a non-invasive test should not rule out LSD-PH in the presence of cardiovascular risk factor.
I absolutely agree with this statement, but I think it's not in the right context here.
Okay.
This patient, this case, this echocardiogram, the probability of left heart disease related pH is extremely low. This is true when the RV is not as enlarged, your PA pressures are not as big. and your left atrium is, not normal in size.
So
And then you would want to do certain provocative maneuvers, but that would be more when you're doing, invasive testing like right heart catheterization and
So you mean if we can have echo low or intermediate probability, then
Yeah.
we could have. Okay,
Yeah.
fine. So Dr. Abhijit, COPD with PH, is it still a diagnostic consideration here?
I think we can keep it in the background looking at the lung function, but we can still not completely rule it out.
So you are keeping COPD with PH in the differential?
Yes.
Okay.
We can add a prism for this because FEV1 was less
So
than 60.
how common the
70.
PH is there in the prism? Your
it's not
patient
common
has
in the PH.
sufficiently preserved, FEV1 by FVC ratio. Not RV by TLC ratio is almost normal. It's not more than 140%, not much hyperinflation. And then the patient has this PH. So this is why I'm asking, the COPD with PH is still a diagnostic consideration. And Dr. Yeah, please.
Yeah, not here, sir.
Not
Not here. In
Not
this
here?
case, yeah.
Okay. Dr. Abhijit says yes, we should. Dr. Vinay says not here. ILD with PH. Dr. Abhijit?
So we've ruled out ILD with looking at the scans.
So not a consideration. Toxin already told by Dr. Tala is not a consideration. PA obstruction, not a consideration. Idiopathic PH with comorbidity.
Definitely high on the list.
So we are coming with some differentials at this point. COPD with PH, idiopathic PH with comorbidity. Which one we keep higher?
I think the
Idiopathic PH with comorbidity. So how would you like to investigate now? What would you do to confirm, or are you sure that this is idiopathic, you are not going to do anything else?
I think look at the next step would be we've done everything we could from the point of view of looking at how the lung is behaving. But now comes the vascular part. So I think possibly right heart cath would be the way to go.
Yes, sir.
Before proceeding further, I think like once we should try to get a good CT chest.
Good.
Good CT chest, HRCT chest.
So we have done
Before
the
we
HRCT
exclude
chest.
that.
So we have done the
lung
HRCT,
problem.
sir. There is no parenchymal lesion at
No
all.
parenchyma.
Yes.
That is okay then.
So do you agree to go ahead with the right heart catheterization in this patient?
Yes.
Okay, Dr. Tala.
Absolutely, unequivocally, yes. I mean, I don't think we should beat around the bush, just go to
Yeah. So I'll especially would like to draw your attention to the 7th World Symposium on PH, what it has to say. Whenever you ask for the RSC, you have to answer two questions. Whether it's going to increase any further meaningful information out of it, and the second, is there any therapeutic consequence to it? So could you please answer these two questions in the present patient's clinical context?
I think just going back one slide, one more thing, I'm just playing the devil's advocate here.
Yeah.
We don't often see idiopathic PH arise suddenly at 77 years of
Yeah.
age. So that just from off the bat, when I read your first slide, 77-year-old, I said, oh, can't be idiopathic PH. But we've seen, every year we probably see 3-4 patients out of 50, 60 new group 1 PH. We do see these. So I wouldn't completely rule out. Definitely in this case, right heart cath is going to add more. It is going to clarify your diagnosis, clearly tell us whether this is pre-capillary or post-capillary. And if this is pre-capillary with a normalish HRCT, it's pointing more towards your group 1 PH, and then we can concentrate more on group 1 PH related pulmonary vasodilator therapy. So, and also it's going to give you certain variables which are going to help in risk prognostication. So not only it's going to make your diagnosis clear, it's not only going to affect your therapy, and number 3, it's also going to help you in risk prognostication. So all the 3 which are extremely important in PH management, you're going to get your answers for that.
So is it going to have a therapeutic consequence too in this patient?
Absolutely, yes. That's what, once we prove that this is pre-capillary PH, group 1 PH, then we can offer PH therapies to this patient.
So what is unusual about idiopathic PH in this case? I would like to point out 2 cases, because I guess everybody is not thinking of idiopathic PH only. Nobody has any other differentials. So what are the unusual things? Severe hypoxemia. This is quite unusual in idiopathic PH. Severe reduction in DLCO. DLCO less than 45%. very rare in idiopathic PH.
So this was one of the main sort of teaching points that my PH mentor, Dr. Ray Benza, used to always tell me, that PH doesn't really cause severe hypoxemia unless we are in sort of very, very advanced disease where the RV is failing and the patient is syncopating, repeated syncopes. And the other thing he told us that, always told me, was that DLCO is a poor man's way of assessing the pulmonary vascular resistance. It tells us what, at least in the PH world, it tells us how much pulmonary vascular remodeling has happened, which is an indicator of severity of the PH. So definitely severe hypoxemia is something that doesn't fit in with idiopathic PH here, number one. Number two, also the age. I would just like to point that out again.
So, Dr. Narendra, points against idiopathic PH, only diagnosis now you are considering is idiopathic PH.
I could say that relatively preserved lung functions with
Yeah.
severely reduced DLCO.
So
And,
anyway,
if you do a right heart catheterization, we will know what are the.
so are you sure of any diagnosis at your hand at this point of time?
Based on information available, I could say that it may be a idiopathic PH with comorbid conditions.
Okay.
The other thing I would probably add was a possible third differential, rare, but should be there, is pulmonary veno-occlusive disease, which
Yes.
can explain the hypoxia.
Yeah. So that's there. In group 1, PVOD is the one which has, severe hypoxemia and reduction in DLCO. So we did this right heart catheterization. So, Dr. Sanjay sir, would you like to please comment on what is the hemodynamic subtype here? Not the entire findings, just the hemodynamic subtype.
Hemodynamically, it appears to be class 1.
Sorry?
Precapillary.
So precapillary. Yeah, it seems to be precapillary, but I would draw your attention, Dr. Tala, here once again. Pulmonary artery vest pressure. Do I want you? Fine. So pulmonary artery vest pressure. Do you want to give any message about this when your patient has the risk factor of coronary artery disease?
Yes, so so there's a lot to talk about here. I think we are running short
Yeah.
of time here.
So just,
But the pulmicapillary wedge pressure is often misinterpreted and wrongly obtained in right heart catheterizations. The waveform here is decent. The right bottom is the pulmicapillary wedge pressure waveform, hopefully, and that's decent with a lot of respiratory variations. But someone has taken the efforts to go into the left ventricle and also get a left ventricular end diastolic pressure, which is preserved. So I would say yes, predominantly it is precapillary pulmonary hypertension. Again, the point that you were making, resting hemodynamics should
Yes,
not rule
yes,
out left.
yes.
This is where it would be more relevant. This is where we would do a fluid challenge, which was done. I would say mild increase in the left ventricular filling pressures, pulmicapillary wedge pressure from 13 to 17 after a fluid challenge. What would be more interesting is noting what that did after the fluid challenge to the PA pressures, which is not mentioned here.
yeah, it's not.
Sir, it's there.
Post-fluid challenge
Yes.
PA pressures are not
17.
mentioned.
17.
Is that post-fluid challenge
Yes,
or
yes,
resting?
yes. Resting is 13.
was
13.
Resting is
Above.
13.
No. The PA pressures,
Okay, PA pressure is not
yeah.
there.
So if that increase in wedge pressure from 13 to 17, is that driving up the mean PA pressure from 49 to 60,
Okay.
70, or is just going up from 49 to 50, 55? So there may be mix, sort of overlap that could be contributing towards the pulmonary hypertension. Over here, predominantly a precapillary component with maybe, very little 4-5% component of postcapillary pH is what this right heart cath tells us.
So with this precapillary hemodynamic and right heart cath, what is your final disease and what is your final clinical classification?
We didn't do any other maneuvers here?
Sorry?
We didn't do any other maneuvers here?
No, we didn't.
Okay. Pulmonary vasoreactivity testing?
Not done.
Okay. So the reason I ask this in this context is because it would have really helped us rule out pulmonary veno-occlusive disease. Pulmonary PVOD tends to hide in the most weird manners in, right underneath our nose, that HRCT with, ground glassing or air trapping can easily be pulmonary veno-occlusive disease. One more thing, we should never label PH as truly idiopathic unless we do a full genetic testing. We
Fine.
didn't do that. Idiopathic means we don't find an etiology. If we haven't ruled out genetic, you can't really
So what
label
we
it.
did is, we thought of this patient as group 1 PH with comorbidity. We started the patient on phosphodiesterase 5 inhibitors, and the dose of loop diuretics were increased. In between, we had the test report of genetic test. It was negative genetic test. Then there was, at the end of 4 months, there was no clinical improvement, and there was worsening hypoxia. So we did imaging to look for the PVOD. On imaging, there was no suggestion of PVOD, and we had the repeat RHC. PVR increased, not much decrease in the mean pulmonary artery pressure.
I'm curious, why not a dual therapy upfront? This is severe PH. By all means, we should be putting here.
We thought that the patient is having some kind of cardiopulmonary comorbidity, and we thought of starting a single drug.
But the right heart cath clearly told us that it is pre-capillary.
Yeah.
So I think we should be, at this age, if you look at any paper, any guideline, whatever society, severe PH, and this is pre-capillary, you've done the hard work, you've done the right heart cath, you've proved that this is pre-capillary PH, dual upfront therapy. Single drug therapy for PH is a thing for significant PH is a thing that we used to practice very, very old. The Ambition trial told us very clearly, don't do that. This is the way to go. Yeah.
So we then modified the treatment. We stopped the phosphodiesterase 5 inhibitor because PVR was rising. There was significant hypoxia also. So we continued the high-dose diuretics. We initiated the palliative and supportive care, but the patient succumbed to progressive right heart failure at 8 months. Now the question is to my panelists, any one of you, was clinical classification wrong? And was so initiating pulmonary vasodilator in the first instance?
As I said, I think we could have been more aggressive with PH therapy and stepped it up within a matter of 2 to 3 months to triple therapy before knowing. I think excellent case, genetic testing doing is sort of, ties a knot on the whole thing. And unfortunate that we lost him to right heart failure, but I think we could, where we could have made some improvement, looking back in hindsight, is just being more aggressive with pulmonary vasodilator therapy.
So I'll come to that also.
I just
but
have a question,
yeah, sure.
Dr. Talha, if you may allow. This patient, idiopathic PH, we confirmed with cardiopulmonary comorbidity. If we risk stratify, yes, this is high-risk patient. But can we start a dual therapy if there is comorbidity?
Absolutely, yes. So just presence of comorbidities or risk factors does not mean that they are causing PH. In fact, this is exactly why the classification, the clinical classification in the 2024 WSPH guidelines changed the wordings from PH due to left heart disease, PH due to lung disease, to PH associated with lung disease, PH associated with left heart disease, which purely means that presence of a risk factor doesn't mean that your PH is due to this. It could be phenotypically different. So it doesn't rule out the chance of, you using upfront therapy.
What we did, we tried to find out the answer in this case. And we tried to, what we looked for, and we found some treatable traits and phenotyping of the patient in idiopathic PAH. And, with the comparer registry, there are 3 kind of phenotypes were found. The classical phenotype that you were talking about, young female, idiopathic PH, no comorbidity, all fine, precapillary. Left heart phenotype, elderly female, having cardiovascular risk factor, smoking history as usual, not DLCO, not reduced. Precapillary hemodynamics. So idiopathic PH, LH phenotype, precapillary hemodynamics. Now, in this case, we thought this is idiopathic pulmonary arterial hypertension lung phenotype. Mostly elderly male, significant smoking history, DLCO less than 45% predicted, and precapillary hemodynamics. These patients usually have almost normal spirometry, no or mild parenchymal abnormality. But the point is, we were perhaps not wrong in classifying the group. Where we went, we could not phenotype the patient properly. It was group 1 PH lung phenotype. And I would like to draw your attention. In group 1 PAH lung phenotype, we have come from the ambition subgroup analysis where lung phenotype was studied and ASPIRE registry. These patients respond less well to pulmonary pH vasodilator. There is efficacy failure. If these patients are given pulmonary vasodilator, they become more hypoxic, and they in fact have higher mortality risk if they are given pulmonary vasodilator. So do you agree with this?
So we do see this overlap phenomena. This would have been a very good case to upfront, in addition to ERA and a PDE5, to add inhale iloprost.
Okay.
Inhale iloprost does not or should not increase this. The reason this is happening, we have to understand why the O2 requirements increase. It's because of increasing, worsening VQ mismatch. And because of whatever, some part of the lung component. If you do inhale iloprost, that VQ mismatch worsening does not happen as much, and it really helps. The idea is to cut down the PVR as much as possible, which should help with improving the O2 requirements as well.
Yeah, so thank you so much. I believe it's better to debate a question without settling it than to settle a question without debating it. So thank you so much. I would take this opportunity to invite you all. The Arowana Symposium is going to arrange, organize second National Pulmonary Hypertension Symposium, 22nd March, in the city of Zoy, Kolkata. Thank you so much.
Madhukar. Dr. Madhukar.
Yes, yes.
Here.
Yeah, please.
Hi,
Dr. Mahavir Modi.
Hi.
Thank you.
I still feel it is 77 age, ground glass opacity, severe hypoxemia.
No ground glass, sir. No ground glass.
Ground glass, yeah, it was there.
Parenchyma, absolutely normal.
It still looks like PVOD. And considering PVOD, do we give pulmonary vasodilators, or it is hazardous?
So what happened when the patient, worsened with the pulmonary vasodilator, we repeated the CT. There was no ground glass, there was no mediastinal lymphadenopathy, there was no interstitial thickening also. So there was nothing to suggest PVOD on the CT, so we didn't go ahead with that, in that direction.
Genetic testing was also negative. So it rules out.
Thank you so much, my esteemed panelists. I really enjoyed talking to you. And Dr. Tala, thank you so much.
Thank you. Excellent case. Thank you.
Thank you.